He survived a hemorrhagic stroke. I like to point that out because it's different than ischemic stroke, a little harder to recover from. So I've been doing manual therapy on Bob, twice a week, sometimes 3 times a week since August, 30-minute sessions. And we've been focusing on different aspects of manual therapy to help improve his recovery and his walking ability. So today he came in, and it's been a constant complaint for some months now that his foot's come in on fire, nerve burn. He's received some epidural shots in his back. He's gotten injections to calm down the saphenous nerve, and there's still this pain that's in the bottom of his foot that stings him when he has his AFO on. So what I've done is I took emu oil, which, you know, Montana Emu Ranch, you know, no big deal, no kickback from them on that. I use this when there's pain involved, and I just mobilize each of the metatarsals and then separate the toes gently to stretch the muscles out in between the metatarsals, and then upward strokes towards the heart, lymphatic type, and just working through each of the fibers of the fascia, the posterior, the tarsal muscles, the dorsal muscles, and mobilizing the ankle. Now the ankle is locked stiff just from the etiology of the stroke, and he initially started with an AFO that was rigid at the ankle, but we were able to get the physical therapist to prescribe this flexion, or dorsiflexion here, to allow so we could facilitate this motion in his leg, which is extremely important if you're going to gait train someone. Why would you walk someone? I understand drop foot and I understand its application to traditional community, so don't attack me in the comments, but what I'm suggesting is when a guy like me, exercise physiologist, suggests that we need to get some dorsiflexion and we need these tissues to operate properly because we're gait training, which what happens here affects the knee and the hip, and he has hip pain from what's happening down here, which we're addressing, then we need to have this mobility here. So where I come in as that, I can create the joint space using orthopedic techniques, advanced training that I've attended, and mobilize the ankle joint. So now we can get inversion, eversion a little bit here. So now I've mobilized some of it, and I'm slowly but surely doing it. He's not in any amount of pain, as you can tell he's not. And this is going to give us a continuum of success through here, so he can dorsiflex because he can engage. He's innervating his gastroc group, the triceps serrae group with gastric muscles and the soleus. So he's innervating that, so that what happens? What happens with drop foot? Tibialis anterior cannot fire if gastroc or triceps serrae group is locked short. So he's locked long, he's locked short. You can't expect this muscle to lift the toe. So if I achieve dorsiflexion passively, and then we start to work on engagement for tibialis anterior to fire some of the outer peroneus here to help lift that foot, then we will achieve it. So my thing with drop foot, anybody who's dealing with it, is mobilize posterior aspect of leg and loose and innervate anterior side, and we'll start achieving this. Now it's about timing and sequencing when you're actually walking. That's another challenge, but it comes with skill training. So all that said, we're getting good mobility in the ankle now. Pain, where you at, Bob?
It's down way low.
Weight is lower than definitely what it was. If you had to rate it when you came in as a number on the pain scale,
It's about a 4.
about a 4 when you came in, and now what is it?
It's low 3, if not high 2.
All right, so we had a change, so now we can go into our actual therapy session and do some work and ensure that we're moderating good mechanics in his foot placement so that he doesn't exacerbate any pain. So using manual therapy prior to your session, 30-minute session, improves outcomes when you actually do your therapy, and that's my big point there, is application, outcome, and benefits. Means his quality of life improves.